The final speaker on the panel is Mary Badame. Mary has several years of experience working with high-risk clients across the whole spectrum of pregnancy and advocating for reproductive justice in Western New York. She serves as the upstate board member for the New York Abortion Action Fund, which supports anyone who's unable to pay fully for an abortion and is living in or traveling to New York State. Currently, she works at the intersection of reproductive health and justice system reform as the Buffalo Patient Navigator with the Center for Court Innovation. Her previous roles include birthing center coordinator, abortion counselor, medical scribe, and intake coordinator at Women's Services in the Birthing Center of Buffalo, where Dr. Morrison is, as well as a community engagement associate at Planned Parenthood of Western New York. She holds a BA from Oberlin College and a master's in global gender studies from here at UB. Additionally, she's the advocacy chair for the Western New York Perinatal Task Force and a certified full-spectrum doula. So it gives me great pleasure to present Mary Badame.
I don't know that I've ever held a microphone before, so I'll do my best. But I'm here to speak a little bit about some of the financial barriers to abortion access and the work of abortion funds to promote access and eliminate those barriers. So firstly, we have to talk about the Hyde Amendment if we're going to talk about financial barriers to abortion access. The Hyde Amendment has been called the grandfather to all abortion restrictions. It was first passed in 1976 and has been in effect since 1977. Its passage was a blatant response to the legalization of abortion through Roe v. Wade, as evidenced by this repulsive quote by Representative Henry Hyde. I would certainly like to prevent any woman, if I could legally, anybody having an abortion, a rich woman, a middle-class woman, or a poor woman. Unfortunately, the only vehicle available is the Medicaid bill. The Hyde Amendment is renewed every year by Congress since its passage as a component of annual spending bills. And it bars federal abortion coverage except when the person's life is at risk or in the case of rape or incest through the Medicaid, Medicare, and child health insurance programs. Fortunately, despite the Hyde Amendment, 17 states cover abortion care through their Medicaid programs. Only 4 do so voluntarily. Those include Hawaii, Maryland, New York, and Washington. The other 13 are under court orders that state less extensive coverage is in violation of their state constitutions. This is a map that shows the states that offer abortion coverage through their Medicaid programs. Although Arizona and Illinois are listed, they are not compliant with their court orders, which in practice brings the number of states that provide abortion coverage through their Medicaid programs down to 15. In these 15 states, 89% of abortion patients with Medicaid use their insurance to access the care they needed. Hyde disproportionately impacts people of color, poor people, and young people. The number of individuals affected is vast. Of women aged 15 to 44 years enrolled in Medicaid in the United States, 60% live in the 35 states or the District of Columbia that do not cover abortion. This amounts to roughly 7 million women of reproductive age, 3.4 million of whom are living at or below the federal poverty level. Of the 7 million women potentially impacted by Hyde, more than half identify as people of color, and among women with Medicaid coverage subject to the Hyde Amendment who seek an abortion, 1 in 4 is unable to obtain the care they need and is forced to carry an unwanted pregnancy to term. Even Hyde Amendment exceptions for rape or incest are incredibly impossible to access. The crime must be reported, you must prove it, and in most states you still have to pay out of pocket for your procedure and wait for insurance reimbursement to come through. Additionally, Congress and the executive branch have used the Hyde Amendment as a model to limit abortion access for people who get their health insurance or health care through the federal government in other ways. The people impacted by these additional abortion bans include federal employees and their dependents, military personnel and their dependents, Peace Corps volunteers, American Indians and Alaska Natives, and people held in federal prisons or detention centers. Like the Hyde Amendment, many of these abortion bans are built into annual spending bills and are renewed each year by Congress. A confusing private insurance landscape exacerbates the problem of economic barriers to abortion access. 26 states restrict abortion coverage in private plans offered on their insurance exchange, and 11 states restrict coverage in all private plans. Even in states that do not impose limitations on private insurance coverage, insurers can choose whether or not to offer the service to their members. Furthermore, some impose restrictions that conflict with the realities of how abortion care is provided. So these might include age restrictions, like only people over the age of 15 can have abortion covered by their insurance, or restrictions based on trimester, only abortions in the first trimester. Also requiring medication abortion to be dispensed by a pharmacist rather than a doctor, which is just not what's normally done. Low Medicaid reimbursement rates in states that do cover abortion, as well as this confusing private insurance landscape, puts clinics at risk. Many clinics are just breaking even, and some even operate at a loss. In addition to procedure costs, patients must consider travel expenses, childcare, and miss pay from taking days off work. Although the abortion rate is declining and currently is the lowest it's been since we started keeping track in 1973, abortion is increasingly concentrated among people who face economic barriers, people who are economically disadvantaged. Low-income individuals face barriers to accessing accurate health information, affordable contraception, and preventive care in general. According to Guttmacher, 75% of people who obtain abortion care are economically disadvantaged, and 49% are living at or below the federal poverty line. The average cost of a first trimester abortion, the last time we took an exhaustive survey, was $480. The financial burden of abortion creates a huge barrier to access. One study found that for more than half of people obtaining an abortion in the United States, the procedure, their travel, and other necessary expenses was equivalent to upwards of 1/3 their monthly personal income. Our clients at NIAF report foregoing utility bills, not paying rent, and not buying groceries for themselves and their children in order to pay for the procedure. Many delay obtaining an abortion due to the lack of financial resources, which can begin an unfortunate cycle that leads to additional costs for care later in a pregnancy and further delays. Abortion funds are grassroots organizations that work to combat economic barriers to abortion access. Funds may provide financial assistance to help people pay for their procedure, travel to a clinic, or stay at a motel overnight. There are over 100 abortion funds in the United States. Our work is explicitly intersectional and movement generating. We recognize that reproductive justice cannot be achieved without economic, racial, and gender justice. We also see abortion funding as an opportunity to build collective power while combating stigma. The New York Abortion Access Fund, or NIAF, is our local abortion fund here in Buffalo, and we're also the largest abortion fund in New York State. Our mission is to support anyone who is unable to pay fully for an abortion and is living in or traveling to New York State by providing financial assistance and connections to other resources. NIAF is an all-volunteer run organization. We're led by our board of directors, and the board, along with our team of volunteer case managers, serves on patient intake, where we are responsible for responding to client and clinic calls on our designated helplines, as well as requests for assistance via email and social media. As Vanessa spoke to earlier, there is still a lot of work to be done in New York State. Yet we are still largely free from the additional restrictions that we see in other states, such as mandatory waiting periods, trap laws, and parental consent laws. Because we have fewer restrictions, we have more providers, and our abortion rate is more than twice the national average. Many people travel to New York from other states and countries to access care. The reasons people travel to New York are varied. Some find the procedure is more affordable in New York than in their home state. Others come from places where there are no abortion providers. And some travel to avoid restrictive laws or because they need procedures during later stages of pregnancy. We are also very fortunate in New York State to have public insurance coverage of abortion care. Despite this, many people fall through the cracks. So at NIAF, our clients may make too much to qualify for Medicaid, but not enough to pay for the full cost of an abortion procedure, which in New York State ranges from about $400 up to $7,000. Many people have private insurance plans that do not cover abortion. As we talked about earlier, the infringement of religious organizations on health institutions, such as insurance institutions, has greatly affected what procedures are covered. A lot of people also have high deductible plans or opt not to use their insurance due to privacy or safety concerns. Maybe the primary policyholder is an abusive partner or a parent that they don't want to tell. They may also be accessing abortion at a clinic that is not in network with their insurance plan or traveling from another state and unable to use Medicaid. In fact, during 2016, 62% of our clients at NIAF were insured at the time we made a pledge to fund their abortion care. This is just some additional data on our client demographics. 63% of our clients identify as people of color, 58% are already parents, and the average age is 26. And this is pretty much consistent with abortion throughout the United States. We currently maintain 3 volunteer-run helplines, one for people living inside New York City, one for people living outside New York City, and one for Spanish speakers. Volunteers call clients back within 24 hours, although after serving on intake, it's normally just a few hours, if that. Through a standardized intake process, we work with each client to quantify the amount of funding that's needed, and then we work proactively to reduce the monetary gap by providing preliminary Medicaid eligibility screening and referral, as well as negotiating discounts with abortion clinics and reaching out to other national and state funding sources. And then we ultimately make a pledge directly to a clinic on behalf of the client for the remaining amount of the procedure. For the last 3 years, I'm very happy to report NIAF has been able to help every person that's called our helpline through either financial assistance or connection to other resources. In our current hostile climate, the need for abortion funding is on the rise. So in 2016, we pledged $216,044 towards our clients' procedures, which represents an increase of 58% in pledged monies over the past 2 years, or over a 2-year time span. We were able to provide financial assistance to 510 individual clients who accessed abortion care at 32 different clinics, and our average pledge is $426.61. In 2016, 36% of our clients traveled from out of state to obtain abortion care in New York. Most came from neighboring states. Of the people who traveled, 44% were from Pennsylvania and 20% were from New Jersey. It's notable that 15% of our clients who traveled to New York for care are from the South, where trap laws, among other restrictions, are forcing clinics to close. While nationally, only 11% of clients seeking abortion care are past their first trimester of pregnancy, 30% of NIAF clients are in their second or third trimester. Because the cost of abortion care typically increases with each week beyond the first trimester, this later care results in larger gaps between what a client can pay and the full cost of an abortion. Clients who travel from out of state are more likely than New York-based clients to be seeking care in their second trimester or later due to a lack of financial resources, fewer providers, and legal restrictions, among other structural barriers. And as I'm sure you're all aware, one of the recent tactics state legislatures have used to limit abortion access is to pass so-called fetal pain bills, which ban abortion after 20 weeks gestation. 17 states currently impose such abortion bans, and this creates a significant need for people to travel out of state to access later care. We've noticed a consistent increase in the distance clients must travel after 17 weeks of pregnancy to get the care that they need. And internally, NIAF has moved to incorporate the reproductive justice framework by incorporating an extensive restructuring of our intentional internal practices and standing up for our sister movements and allies. Thanks to our focus on creative collective power, we are on track this year to fund more clients than ever before. This is a picture from our 2017 bowl-a-thon, where we had 544 registered bowlers. A lot of our work is fundraising. So we're all volunteer-based. That's the bulk of the work, as well as direct client contact. We had a bowl-a-thon last year in New York City and Buffalo, and I'm very excited to say this April we'll be having bowl-a-thons in New York City, Buffalo, Rochester, and Albany. So we very much hope that we can see you there. We have lots of fun events. We try to see, the humor and the light and the community in abortion funding. So, yeah, that's my